Hello everyone. Welcome to part 4 and the last of the lecture series on armamentarium for local anesthesia. The topic is preparation of patient. Well, who said it's only the patients who are anxious in dental clinic? Sometimes we dentists also undergo the same stress in trying to achieve the perfect anesthesia. Managing the oral cavity as well as an anxious patient can be quite challenging. Certain arrangements are required before the actual process of administering local anesthesia. So, this lecture aims at all the pre-anesthetic preparation or conditioning of oral tissues as well as the patient to ensure effective anesthesia and patient comfort. The support system includes various materials and instruments which are used to prepare the patient or the tissues, aligning with our objectives of painless delivery of anesthesia, patient comfort, patient safety, and dentist protection. To begin with, the topical antiseptic. This would be the first step to consider before any injection. Unfortunately, it is not followed by many. It is a common practice to disinfect skin before any hypodermic injection to avoid introduction of microbes into deeper planes through a needle. Similarly, oral cavity also deserves the same because this is more fulminant with microbes. So it is definitely a good practice to start with a topical antiseptic. Let's remember it definitely produces transient decrease in bacterial population. Remember, oral cavity is just second to the gut in harboring the maximum number of microbes. The topical antiseptic is placed at the site of injection using an applicator stick. The available agents include povidone iodine, what is commonly called as betadine, and thimerosal. Topical antiseptics containing alcohol should not be used because the alcohol produces tissue irritation. In addition, allergy to iodine-containing compounds is common. Before any iodine-containing topical antiseptic is applied to the tissues, the patient must be questioned to determine whether adverse reactions to iodine have previously developed. The application of any antiseptic is for a duration of 15 to 30 seconds. There is no need to place a large quantity on the applicator stick. It should be sufficient just to moisten the cotton portion of the swab. Post-injection infections, although extremely rare in dentistry, can and do occur. The routine use of a topical antiseptic can virtually eliminate them. If a topical antiseptic is not available, at least a sterile gauze wipe should be used to prepare the tissues adequately before injection. Next, we move on to the topical anesthetics. These are familiar to us. Most of us use them. These have multiple uses in various fields of dentistry. To anesthetize soft tissue before needle insertion, to reduce gag reflex before taking x-rays or impressions. Some patients cannot tolerate them at all. Management of alveolar osteitis before you actually explore into the dry socket area. And also to reduce sensitivity during periodontal probing, gingival curettage, and orthodontic band placement. The common formulations used are benzocaine, lidocaine, and EMLA, eudectic mixture of local anesthetic lignocaine and prilocaine. These are not ideal for intraoral use because they are bitter. But in contrast to the earlier preparations, topical agents of today are not bitter to taste. These are available in various flavors and potency, and hence these are more patient oriented. And these topical anesthetics are available in numerous forms as ointments, gels, pastes, and sprays. So, how do we choose from these? Well, the first requisite to choose would be the speed of action. The fastest to act is a spray form, and hence the most popular form. But one needs to be mindful of the safety aspect of any drug formulation. Remember, the dose delivered by a spray is 10%. One press delivers about 100 microliters, which is 10 milligrams of local anesthesia. So, if you do the math, you know how serious this is. On this aspect, gels are safer Additionally, the area covered by gel can be more specific as compared to a spray. A very important point to note while using sprays is to use a metered valve dispenser, which is much more controlled in delivery. The next concern is about sterilization. After the first use, the solution is non-sterile. Also, regarding the nozzles, while using, they get in close contact with the patient. Hence, one nozzle a patient is recommended. You could order the nozzles separately. The other novel form of local anesthesia delivery topically is the local anesthetic patch. A patch contains 10 to 20% of lignocaine. This is placed on the dried mucosa for 15 minutes. The patch is recommended for use in achieving topical anesthesia for both maxilla as well as mandible. The next on the list are metallic instruments like pliers called the hemostats. These are used to clamp blood vessels and control bleeding. These are also called as hemostatic clamps or arterial forceps. Although not considered an essential element of the local anesthetic armamentarium, a hemostat or pickup forceps should be readily available at all times chairside in the dental office. Its primary function in local anesthesia is removal of a needle from the soft tissues of the mouth in the highly unlikely event the needle breaks off within the tissues. Gauze is another useful addition to local anesthesia armamentarium. These are light, open weave fabric made of cotton used to control bleeding. Basically, they absorb blood, moisture, and come in size of 2 into 2 inches. Cotton gauze is included in the local anesthetic armamentarium for two reasons. First, wiping the area of injection before needle penetration. Second, drying the mucous membrane to aid in soft tissue retraction for increased visibility. Gauze effectively dries the injection site and removes any gross debris from the area. It is not as effective as the topical antiseptic, but it is an acceptable substitute. Retraction of lips and cheeks for improved access to and visibility of the injection site is important during all intraoral injections. Often, this task becomes unnecessarily difficult if these tissues are moist. They are made even more vexing when you wear your gloves. Dry cotton gauze makes the tissues easier to grasp and to retract. A variety of sizes of cotton gauze are available for tissue retraction, but the most practical and the most common one is the 2 into 2 inch size. Larger 4 into 4 inch gauze squares are much preferred as they minimize the risk of aspiration of the gauze into the posterior pharynx, leading to, sometimes it can happen, leading to airway obstruction. Additionally, it is very important to remember that whenever gauze is placed into and left in the mouth for a period of time, a length of dental floss, as what is shown in the picture here, should be tied around it so that, if necessary, the gauze may be removed or retrieved from the mouth quickly. We now move on to the next category of instruments which are essential for protecting a dentist. The first of the category is a needle recapping device. These are specialized tools designed to safely recap needles after use and to reduce the risk of accidental needle stick injuries. According to the Center for Disease Control and Occupational Safety and Health Administration, prevention of needle stick injury should be done by using either a one-hand scoop technique or a mechanical device for holding the needle cap when recapping needles between procedures. But the scoop technique is not always convenient because as you try to scoop the needle, the cap may just keep moving away. So we have a different kind of a solution called as the needle sheath prop. This serves as a prop for single-handed scooping technique. So the needle sheath prop is heavyweight, single-use autoclavable paper. Let's check how it is used. All you have to do is simply place the needle cap onto the designated slot on the prop. This allows you to hold the cap securely with one hand while guiding the needle onto it to recap after administering an injection, like what is shown in the picture here. This promotes a safe one-handed recapping technique as recommended by safety guidelines. Numerous designs for needle protection between procedures are available. So to choose them, these are the features that you need to look for. It should be easy to guide the needle into the cap. The device must hold the cap firmly. There should be no need to hold the cap. Also, it should be usable with reusable or disposable syringes. These are the various designs available in the market. Choose your design according to your convenience. Now, after we are done with the procedures, how do we protect the other handlers who work in your facility? Remember, the devices, especially like the syringes and the needles, need proper disposal. Needle disposal must be done by using either a sharp storage or a cartridges container. The sharps destroyer is typically the needle burner or the syringe destroyer like what is shown here. The next support system of great importance relates to the problems due to prolonged anesthesia. Sometimes we don't want anesthesia to persist, especially the anesthesia related to the lip and the tongue. So is there a quick antidote or a reversal agent? Yes, we do. Oraverse, which is phentolamine mesylate, is the first and the only local anesthesia reversal agent. In fact, it is called the local anesthesia off switch. The aspects of the post-local anesthetic experience that are generally disliked by patients include three major areas: functional, sensory, and perceptual. Functionally, patients dislike their diminished ability to speak because of lisping, to smile, the face becomes asymmetric, and to drink because liquid runs from the mouth or even when you eat, and the inability to control drooling while the face is still numb. Sensorially, the lack of sensation is described as quite discomforting, while the perception that their body is distorted. This frequently happens because of anesthesia. Patient feels that their lips or the cheek are swollen. This is also equally unpleasant. Also, residual soft tissue anesthesia may occasionally lead to self-inflicted soft tissue injury of the lip or the tongue. This is more likely to be noted in younger children and in mentally disabled adult and pediatric patients. So, it is very important that these effects are reversed as quickly as possible in this category of patients. Oraverse acts against vasoconstrictor, which prolongs the duration of action of local anesthetic agent. So this must definitely be part of your armamentarium. Now, to a scenario that most of us do not wish to be in. When local anesthesia just wouldn't work, in spite of our perfect technique or multiple injections. This is when this comes handy. The local anesthesia on switch, which is an alkalinizing agent. Frequently used agent is the sodium bicarbonate, about 8.4%. This is very effective in elevating the pH of local anesthetic solution, which automatically improves the efficacy of local anesthetic agent. Now, how do we achieve this? When the quantity needed is more and you want to use a disposable hypodermic syringe, all you have to do is use 2 ml of sodium bicarbonate, like what is shown in the picture here, and you add it to 20 ml of lignocaine, 1% or 2%. So this makes up the desired mix of the sodium bicarb solution. This is much easier, but you have to remember that this has to be used up immediately. Otherwise, the solution would undergo precipitation and it may not be giving the desired effect. Now, when the quantity needed is less and you're going to use a disposable syringe, again, you mix 0.1 ml of sodium bicarbonate to 1 ml of lignocaine, 1% or 2%. And this is how you make the mix. So what do we do when the quantity needed is less and we would like to use a cartridge? This is how it is done, but you need an insulin syringe for this. So the first method is 0.1 ml can be pushed into a cartridge with an insulin syringe. Now the plunger moves out to accommodate for the space taken up by the sodium bicarbonate. With the second method, you initially create space in the cartridge by pushing 0.2 ml out, and then you inject 0.25 ml of sodium bicarbonate, and then you have your mix ready for injection. But when you don't want to do the buffering manually, well, you could use the automated buffering systems. Popular ones are the OnPharma and the Enutra systems. These are very quick. Buffering occurs in seconds. These are chair-side simple devices wherein the buffered solution is more reliable and predictable, and this is going to keep your practice on time and on schedule. There's no need to change your syringe or learn a new injection protocol. Once buffered, you place a local anesthetic cartridge in your own syringe and give the injection using your own injection technique. So you must consider using these systems. Let's now move on to some novel ideas and devices that could aid in pain control. The vibration devices. These devices stimulate the non-painful nerves, especially vibration, to prevent transmission of pain by using the gate control theory. In simple words, these devices distract the brain from painful stimuli. The various devices available in the market include Vibroject, Dental Vibe, and Acupal. The Dental Vibe is a handheld cordless tool with a soft disposable fork tip like what you see in the picture here. And these devices deliver gentle vibrations consistently to the injection site once they are switched on. They also help in retracting the tissue and illuminate them. And these can be used before as well as during injection. The Vibroject is a small vibrating device which can be attached to a standard syringe. It is actually a dental accessory, and these are battery operated and they are less expensive. Colgate 360 Advanced Sonic Power Toothbrush can also be used for mucosal vibration. Many studies have been conducted which have established the effectiveness of these brushes in eliminating pain by counter stimulation. Another interesting system is a buzzy system. This is a simple and easy to use device which has been developed to prevent pain from needle related procedures in children. It is a B-shaped device as what you see in the picture here and consists of a main vibrating body and two removable eye swings. The main vibrating body is power driven by two alkaline batteries which can be started by a switch on the top of the device. The eye swings contain 18 grams of ice and they are inserted at the back of the body with elastic bands. The device is placed in close proximity to the site of local anesthetic injection and then kept activated throughout the injection period. So current research in dentistry is focused on the usage of cold temperatures in addition to the vibration device. The rationale for use of this technique is that as a psychological component, pain is reliant on the perception as well as the attention of the patient. When administering dental anesthesia, it is important to remember that not all patients are the same. It is essential to tailor the armamentarium and the technique to each individual patient. This personalized approach ensures effectiveness, minimizes complications, and addresses unique patient needs. Several factors must be considered when selecting the appropriate armamentarium for a given patient, including their medical history, anxiety levels, age, and the complexity of the procedure. So let's try to focus on the patient-specific considerations for the dental anesthesia armamentarium. Administering local anesthesia to pediatric patients presents unique challenges. Preparation of these patients requires two components, mental and physical. So you can consider the following ideas while handling a pediatric patient. Consider using short needles or ultra short needles because of the fear factor towards needles in these patients. Also, these short needles are ideal because of the lesser tissue penetration depth required in these small individuals. Sometimes you can also consider the use of needleless techniques. And to distract the patient, we could use the vibration based equipment. Funny shaped sheets can also be used to cover the syringes. I would be showing in the subsequent slides. These sheets can also be used to cover the syringes to distract a pediatric patient. Also, consider a single tooth anesthesia because in these patients you wouldn't want exaggerated periods of soft tissue anesthesia, especially involving the lip or the tongue. There is a debate among clinicians as to whether the syringe and its components should be assembled in view or out of view of the patient. Proponents of assembling the syringe in view of the patient assert that doing so acts as a desensitization technique, while proponents of assembling the syringe out of the patient's sight assert that most children have developed a fear of the injection during prior visits. So it is preferable to assemble the syringe out of sight. But it is also desirable to distract the patient when receiving the anesthetic syringe from the dental assistant. Or you could also consider using a syringe with attractive syringe sleeve, like what is shown here, the Angie syringe sleeve. These are definitely less menacing and these are more receptive by the pediatric patients. Distraction is definitely a very effective method in pain management or anxiety management in children. Distraction as a behavior guidance technique is defined by the American Academy of Pediatric Dentistry as a technique of diverting the patient's attention from what may be perceived as an unpleasant procedure. Audiovisual distraction techniques are used in dental clinics and have shown great results in managing anxious pediatric patients. Virtual reality distraction, defined as a human computer interface that enables the user to interact dynamically with the computer generated environment, is a new method in the medical field. Now, this has the aim of aiding in patient behavior management. It offers the advantage of immersive virtual experience, which blocks out all the external stimuli that may provoke a negative attitude. Distraction using virtual reality provides favorable outcomes for pediatric patients during anesthesia, such as increased comfort and decrease in anxiety. Now, let's move on to the other end of the spectrum of patients, the geriatric patients. Age related changes result in bone loss and thinner tissues in these patients. Therefore, shorter needles are ideal in this group of patients. The other concerns are related to overdose and aspiration due to the presence of numerous systemic problems in this age group. So, we need to take utmost care to avoid overdose by proper aspiration. So let's use wide bore needles which permit better aspiration and aspirating syringes. Let's not have any compromise on that aspect. Further, in geriatric patients, the presence of infection is common. So for effective anesthesia, consider alkalinization using sodium bicarbonate. And single tooth anesthesia is another ideal method to eliminate unwanted soft tissue anesthesia of the lip and tongue. The other option is using phentolamine mesylate to reverse the action of local anesthesia earlier than the usual duration of action. Anxious patients form another subset of patient population that we would come across, and the anxiety is predominantly due to the needles. So let's try to reduce that by using ultra short needles. Needleless is much better, and use vibration based techniques to distract their focus from the pain. And let's always use topical anesthetics before beginning to use the injection anesthetic. And yes, we will have patients reporting to us with the history of allergy. This is the other major aspect of concern apart from dosage and aspiration. So for these patients, let's remember to choose cartridge without methyl paraben. Also, we could use diphenhydramine in patients who are allergic to both amine as well as ester. And the last is the most important aspect that all of us need to follow. An emergency kit must always be ready to use in a dental clinic because complications are totally unpredictable. Let's be prepared. The other category of patients which need to be handled carefully are the patients who have pre existing infections such as HIV, hepatitis, etc. So, when you handle these patients, you need to exercise extreme caution in avoiding cross contamination. So, please use disposable syringes, disposable needles. Absolutely no compromise on that. And it is good practice to avoid multi-dose vials. Use cartridges. We do not want to make any mistake at all. And at any cost, prevent needle stick injury. Let's take adequate precautions by using safe inject syringes, sheath protect in between procedures. Also, let's choose techniques of delivering anesthesia which are minimally invasive. Intraosseous or even tuttle numb is a good option. Moving on to us. Yes, we dentists need to invest in certain armamentarium for our safety, comfort, and importantly, to prevent long term musculoskeletal problems. When safety is the priority, it is always better to consider designs incorporated in the syringes or the needles which offer extreme safety features to the dentist. You could consider using needle protectors as what is shown here or secure checked syringes. Also, let's try to choose armamentarium which are ergonomic to us. Based on the size of your palm, choose the size of the syringe. There are numerous sizes available. Also, if you do not want to use a heavy syringe, use plastic, ventilated, or stainless steel syringes. Pressure syringes, when used, require only less pressure as compared to the conventional intraligamentary injections. Also, you could think about using computer controlled local anesthetic delivery systems. They are extremely ergonomic to use because you are going to use only the pen grasp. Also, you do not have to focus on multiple things at the same time. Foot control, if you're using a wand, to regulate the flow of injecting the local anesthetic solution. But the most important advantage is the pen grasp, which is ergonomic to a dentist. With this, I come to the end of lecture 4 on preparation of the patient. Now, here's the summary. Let's prepare the site of anesthesia as well as the patient, physically and psychologically. Always remember to use antiseptics and topicals before you initiate the process of injecting local anesthetic solution into the tissues. Incorporate fear or pain distracting devices to augment the experience of painless dental anesthesia administration. Choose patient specific armamentarium. It is very, very effective in achieving good outcomes. Choose dentist friendly equipment, it goes a long way. And do not compromise on sterilization of armamentarium and also pay attention to the disposal devices. With this, we come to the end of our session on armamentarium for dental anesthesia. Before I wrap up, let me remind you today, painless dentistry is very much a reality. One of the big responsibilities of dentists today is the need to raise awareness of what modern dentistry has to offer to the fearful patients. There is so much to explore in terms of armamentarium to ensure painless dentistry. Let's get ourselves updated and invest in good armamentarium for a great clinical practice. At your practice, I wish you all happy smiles, happy patients, and a happy you. Thank you.